Session 3, Aesthetic Session. Moderated by Dr. Mayada El Sawa, Dr. Lara El Haideri, Dr. Jihan Abdul Kadir, Dr. Fatma Madani.
كثير بحبها كثير ملاك ايه
وانتوا بتشوفوا مين بيقدم مين او تشينجينج انه الكويستشن بتصير على الارض
المفروض يعيطولي ولا
دكتورة جهنة تقدم دكتور مريم
Good afternoon, everybody. First, I would like to thank Dr. Nancy for the beautiful symposium. And because pigmentation is a very common problem and very important problem, I would like to invite the Master of Treatment of Pigmentation, Dr. Maria Khattar. She will talk to us about the safety and efficacy of 1927 nanometers non-ablative fractional laser in the treatment of pigmentation. تفضلي دكتورة.
Thank you, Dr. Jihan. And thank you for the invitation. Well, I'd like to present a 1927 nanometer fractional device which has become an indispensable part of our daily practice. These are my disclosures. And we know that our skin is always subject to the ravages of time as to whether it is intrinsic aging due to genetics, hormone balance, and so on, or extrinsic factors due to environmental damage, actinic changes due to UV exposure. All of these things are going on all the time on a daily basis. So where does this 1927 fractional laser fit in? It has an extremely high patient satisfaction. It has relatively low pain effects as compared, let's say, to the other fractional lasers. The procedure is within maximum 10 minutes, you've completed the procedure. And it has, again, a relatively low downtime, as we shall see later on. And the great thing is that it's so safe that it can be delegated to your assistants. The 1927 nanometer fractional laser is non-ablative. It is absorbed by water. And if we look at the water absorption curve in blue, what we can see is there are several peaks of absorption in water by different wavelengths. So this is 1,000 nanometer and beyond in the near and mid-infrared and far infrared ranges. But we can see clearly that the highest peak of absorption is the 2940 nanometer laser, which is the erbium YAG. And the second highest peak is the CO2 laser, which is 10,600 in the far infrared range. So these two wavelengths are so well absorbed by water in the skin that they cause vaporization of the water, desiccation, and therefore damage, resulting in ultimately renewal. Wavelengths below these, in the lower infrared range, there are also peaks of absorption, but these peaks are not very well absorbed by water. They create heat, and they coagulate fractions of skin, thereby resulting in skin death and renewal. So therefore, we have the non-ablative wavelengths that do not vaporize the tissue, and the ablative wavelengths that vaporize the tissue, and this is a distinct difference. So if we look, for example, at the 1927, where does it fit? It's well absorbed by water, it's a good absorption peak, it heats columns of skin, causes coagulation and thermal damage of the skin, thereby resulting in skin death and removal by the body and skin renewal. So it's excellent, really excellent for all superficial pigmentary changes on the face and body. So it's not just the face. You know how many patients we have that complain of dark elbows, underarms, knees, even the private area. It can be used anywhere, face and off face. It is also safe for melasma, and this is something that we always are generally apprehensive when we talk about lasers and melasma. We always think there's going to be a rebound. It's going to get worse than before. But as I will show you, it's been shown that it is really safe because, first of all, the fact that it doesn't target melanin, but that's not the point, but the fact that you have a very little energy density which is delivered to the skin. It also improves textural changes, fine lines and wrinkles, great for pores, and especially PIH after the deeper laser. To tell you honestly, we use a lot of much more aggressive lasers, and we are not concerned about PIH after laser because we are relying on this device if we need it subsequently. And you can stack, of course, in the same session over other lasers. So we know that we always have to treat to the depth of our pathology, whatever it is. And when we're talking about pigment in the main, fine lines and wrinkles and pores, we're talking in superficial laser, so between 50 to 150 micron, and that's exactly what is targeted by this wavelength, up to 300 microns, depending upon the setting. So it is really safe for all skin types, 1 through 6. You can treat all year round. You don't need to just dedicate the treatments to the winter season. And it's ideal for prejuvenation, for patients that are new to lasers, new to skin rejuvenation. And it's great for men because it does not cause hair loss and it has a relatively low downtime. So they can do it over a weekend. And generally we say it's more for patients under 50, but actually anyone can benefit. The way we position this, we talk about polishing the skin. We tell patients it's like you polish your silver. It is quite dramatic in its outcome. If we see here, the device has preset parameters, and we can deliver energies from 5 joule per pixel per point up to 20 millijoules, and different densities from very light density of 5% up to 20%. So basically, if you have a melasma patient and you're concerned, you would probably use this or this number 1 or number 2, delivering less energy. So the deeper you go, the greater the energy, of course, the greater the density, the greater and the deeper the zones of coagulation. So there are a lot of studies looking at increase in collagen production with the 1927 fractional laser, proving that there is both epidermal and dermal thickening. There is even an interesting split phase study comparing it to a 2940 ablative fractional laser for acne scar. Of course, it's not our treatment of choice for acne scar, but it can help for superficial scars. However, the main indication, as we mentioned, is for diffuse hyperpigmentation and actinic changes. Again, we see a multitude of studies proving the efficacy of this device in these conditions. And in this one publication, they looked at the duration of effect of a couple of treatments done 1 month apart to see how long the clearance lasted. And they followed up basically only for 3 months, and up to 3 months, definitely there was complete clearance. Unfortunately, they didn't follow up further than that, but the recommendation was that whenever the patient is exposed, it's a simple treatment that they can do if they have a recurrence of their dyschromia to come back and do a session of the 1927 laser. So in terms of actinic damage, these are some of our results. We can see, for example, this patient, this is a single session. You can see tremendous clearance of all the dyschromias, brighter skin, lighter skin, improved texture. It is such a simple thing. So of course, counseling comes with this. You have to counsel the patient that they have to take advantage of this clearance and take care that it doesn't recur, whether sun avoidance, proper topical skincare. This is another case. This is after 2 sessions. This woman had been somewhere on holiday, no sunscreen. She looked literally gray. It doesn't really show here. This is after 2 sessions. So you can imagine what a psychological effect it has on a patient when they see that they've been cleared of all their imperfections. And this is with subsurface illumination, you can see the pigment reduction as well. So it's objective evidence that we have nice clearing of all of the pigment on her face. And after this, she came for a 3rd session. These people become obsessed, by the way. This is, again, after 2 sessions, you can see amazing clearance of this lady. And she, again, on the face and neck, you can still see there are some stubborn spots on the neck, and she will do another session. What about post-inflammatory hyperpigmentation after aggressive lasers? This is our, if you like, umbrella in the clinic. But the particular case I want to present is a case of a lady who was sent from the UK, because there is a dermatologist in the UK who does full field CO2 laser for acne scars. So he's very famous for that, and he has a lot of patients from the Middle East. So this lady had been to him. Obviously, she has very good results with her scars, but she was left with PIH. So he sent them to us to treat her. We treated her 3 times, and she had very good resolution. She had had this PIH for 6 months prior to this treatment. What about melasma? We know that there are many kinds of melasma. I don't need to tell you that. There's the epidermal, dermal, and the fact that we really need to elucidate with the classical way of checking under the Woods lamp. But the thing about the 1927 is that first, it targets water and not pigment, hence it's safe. Second, it's a shallow penetration. Third, it delivers low energy. This is the main thing. So you don't have heat buildup, and you don't have stimulation of the melanocytes. And therefore, there is almost, to be honest, no risk of PIH. We have not seen any PIH or rebound, quite the contrary. And this is actually a study looking at 14 patients who underwent 3 to 4 treatments with a statistically significant decrease in the MASI score at 1 month of 51%, and to 33% reduction at 3 months. Similarly here, another retrospective study looking at 100 patients with 2 sessions, 1 month apart. Again, statistically significant decrease in the MASI score, and their conclusion, it's safe and effective for melasma. Finally, the third study I want to present is a split face. One side was done with a combination of the 1927 and tranexamic acid taking advantage of transepidermal delivery, and the other side was just the 1927 laser with no statistically significant difference between the sides. So we know that melasma is a chronic condition. We know that they might get it again. So proper patient counseling is very important. But when you are proposing a simple treatment like this with a recovery of 4 to 5 days, they can just come back as and when they need to get clearance. These are now the cases I want to present are cases of patients with melasma and mixed melasma. This patient, she has combination dermal and epidermal melasma, 1 single session, very nice clearance. But we have to be very assertive with melasma patients that if they do not stick to their regimen of creams like sunscreen and inhibitors of melanogenesis, they will rebound faster. So again, very nice clearance, but again, you tell them you have to stay on the creams, otherwise it will come back. So, what about the regimen for melasma especially is to have corrective treatments basically 1 to 3 monthly or 5 to 6 weekly sessions, and then maintenance treatments. It's best to rope them into the maintenance treatments from the outset, because you're telling them about the eventuality of what can happen. And of course, the topicals. So if we see, this is generally a moderate treatment with 10 millijoules, 10% density. You can see the recovery by day 4 is excellent. There's a little bit of erythema the first couple of days. In this case, this was a more aggressive treatment. There was a little bit of sloughing, but it's very manageable. The first few days, makeup can cover it. And if we compare to the other non-ablative fractional lasers or the ablative fractional lasers, there's a big difference in terms of recovery.
Dr. Maria, you have 2 minutes.
Yes. So most of the time we combine with broadband light and the 1927 at the same time. So for example, in this case, each individual pigmented macule was treated with a 3 millimeter spot of the broadband light, and on top, there was done the fractional non-ablative laser with wonderful clearance just in one session. However, post-care, as we said, no direct sun exposure. We give them all prophylactic valcyclovir because we know that 85% of patients have the herpes simplex virus. So in conclusion, it gives us excellent skin tone evenness, skin surface evenness, and with these combined properties of uniform color and texture, the skin acts like a mirror and reflects the light and is perceived by the onlooker as glowing skin. Thank you.
Thank you, Dr. Maria, for your interesting talk. Our second speaker, Dr. Hassan Galadari. He will talk to us about very interesting topic as usual. I believe all of us eager to hear from him. Ethical beauty, cosmetic dermatology, and public health. So Dr. Hassan, the floor is yours.
Thank you so much. Thank you for all the chair people. Thank you for the organizers. Assalamu alaikum al-jami'. So my talk today is going to be a little bit different because I'm going to be talking about ethical beauty, and this is it's a different concept that I wanted to kind of share with you. I've first started looking into it about, I would say, a year and a half, looking at what we do, because a lot of people think that we do a lot of aesthetics, cosmetics, and so forth. Is there any ethical repercussions that entails upon us, or at the same time, does it really have an effect on society in a sense? So what we're going to be talking about is that this is the introduction. First of all, there are no conflicts of interest here for this presentation. We're going to talk about the growing popularity of aesthetic medicine, and everybody here probably does a little bit of aesthetics, I'm sure. There's also going to be there is a rising demand in public health when it comes to thinking about it, especially when it comes to the implications. And finally, we're going to talk about a little bit on the crucial role between pretty much talking about the individual desire and also the societal well-being. So let's talk about the ethics of beauty. Now, beauty has to be ethical because without ethics, everything basically kind of goes haywire. Beauty is not just about looks. It's the way that we carry ourselves. It's the way that we introduce ourselves to each other. It's the way that we communicate with one another. Everything basically comes to the fact that it's considered to be more on the beautiful aspect of things. Beauty is what, a person is going to ask themselves, what is beauty? If you feel comfortable sitting next to the person next to you, or if you feel comfortable communicating with another person, that in itself is considered to be beautiful. Okay, that is the definition of beauty. Beauty pretty much is that feeling that you have that makes you pretty much feel more at ease when it comes to the other person. If the other person that you are next to, or it can't be just a person, it could be a setting, a place, it could be an object that you have. If you don't feel at ease with whatever it is, that thing is considered to be not beautiful. Now in the past, people talked about, especially when we're looking at civilizations, people talk about suffering that has value. The more you suffer, and also pretty much also in our religion, the more you suffer now, the more you will be rewarded later on. And that is also considered to be more on the beautiful aspect of things. And the suffering pretty much also fosters empathy, growth, and wisdom. The reason why we are wise, the reason why we are, we basically kind of have these different layers of communication that we're able to kind of entail upon other individuals is basically how we have experienced the world. So whether it's good experiences or suffering, pretty much, it allows us pretty much to kind of change our perspective, and we consider things to be a little bit more on the beautiful side. Now we also have to think about that it has a little bit more implications than just the clinical aspect of things. Modern ethics overlooks the emotional and intuitive dimensions. And finally, healing through aesthetics is crucial, okay? Because that's what we do. We take care of the skin. And the skin is something that you're able to see on a regular basis, on a daily basis. Everybody looks at themselves in the mirror when when they're washing their face in the morning. And if we look at the changes that occur with us through time, it can definitely affect us, in a sense, on an emotional level. So when we're looking at, people are going to say like, oh, this is too superficial. We're not thinking about, it has to be a little bit more deep than that. We have to truly understand that how we look really plays a huge important role, because we are able basically to kind of give ourselves confidence based on the way that we look. And you might say to yourself, this is a very, very superficial thinking. It is actually the real thinking. If you're able to kind of make the person look better, they will feel better, they will have more confidence to kind of also perform better with time. And finally, leadership is beauty. Now, let's define ethical beauty. Now, ethical beauty pretty much considers health, inclusivity, and informed consent, okay? It has a number of influences, mainly on society, also body and self-esteem. Informed consent is very important, because this part is when we see our patients and when they ask us, what needs to be done, it is our role as physicians to kind of make sure that we are informing them of what are the implications of any procedure that we're going to be performing on them. And this kind of plays into the role of truthfulness and transparency. Never pretty much over-promise. Okay, so that's basically the transparency. And also be very careful when it comes to targeting vulnerable populations, because you will have patients who have acne scars. These patients are considered to be vulnerable. If you tell them that I've got this great laser that's going to take care of your acne scars, and you know that this laser may or may not work, pretty much maybe not even work, but you're targeting this vulnerable population, here you're basically kind of playing around with that group. And that's where ethical beauty kind of plays a huge role. Now, there is a cosmetic boom. Everybody here in this room probably does at least one procedure out there. And we can't really kind of deny that us dermatologists, we own the specialty. We're supposed to be on the forefront when it comes to any of the procedures that are being performed, not other specialties that are out there. So for us, we truly have to understand, we can't tell ourselves we shouldn't do cosmetics. Cosmetics really plays a huge role in pretty much skin health. And we've understood that skin health also is pretty much reflected on our overall health well-being, because there is a psychological impact, okay, that plays a huge role. Now, cosmetic surgery is a public health issue. If you have patients, for example, coming in with burns, if you have patients coming in with acne scars, if you have patients coming in with even, for example, vitiligo, those type of patients pretty much have a decrease in the quality of life. And, because of that, that can also affect their basically performance when it comes to working, when it comes to being an active member in the society. So when it comes to the things that we're able to perform in terms of cosmetics, it plays a huge crucial role. Mental health has to also take central control. Everybody talks about mental health. Why is mental health quite important? It is because mental health, in a sense, can affect people who have, for example, body dysmorphic disorders, and any untreated psychological issues can increase the risk of developing poor outcomes. And of course, risk of overuse and unmet expectations. We have to be very careful to kind of manage expectations when it comes to our patients. Now let's look at the public health. First of all, access and regulation are uneven. And we understand that, especially in, maybe not here in the UAE, but for example, in different parts of the world, for example, such, sub-Saharan Africa, and this is where I gave this presentation for initially, we truly see that there are certain parts of regions, geographical regions, who don't have access to certain procedures that can help them. Now we think that, acne scars is really not a big, and it's not a big thing. I mean, they can still be able to kind of work, they can still be able to kind of perform with the way that they're supposed to, but you'd be very surprised. Imagine yourself being a public face. If you imagine yourself working as a waiter, imagine yourself working as a receptionist, and you have acne scars. Okay, that will definitely kind of impede your self-confidence. It will, because of that, you will always feel a little bit of shame, and you will not be able to perform in those roles. So a lot of those individuals have, a problem when it comes to access. Now, we as physicians, as dermatologists, or basically as cosmetic surgeons, we have pretty much a huge role when it comes to being public health gatekeepers and taking care of our patients. And this is our responsibility. So in conclusion, cosmetic procedures must be integrated into the public health. And governmental hospitals, even here in the UAE, should have, for example, access to laser treatments for acne scars, for burns. Okay, it is for post-inflammatory hyperpigmentation. It is very, very important that they are able to do this. And our role as physicians is to balance autonomy and also beneficence. It is to identify those sort of vulnerable populations and at the same time also refuse unethical treatments for just the sake of performing them. Now, let's look at the informed consent challenges. This is very important in that aspect, because we can have problems in a sense that it can lead to emotional motivation, misaligned expectations, selective informed retention, pressure and marketing from social media, especially in this age right now. You'd be surprised, there's a lot of posts that are out there that pushes our patients into performing procedures that they may think that's unnecessary. I have had a number of patients come in and telling me they dictate what they want. They will tell me, I want polylactic acid. And I look at them, I'm talking to this patient, and this patient is 21 years old. No, sweetheart, you don't need polylactic acid. You're too young. We don't need to stimulate your collagen. Your collagen is performing as it's supposed to for a person your age. So it is very important for us as physicians to be able to do that. And at the same time, also consent fatigue. Now, equity and access to aesthetic dermatology, and I mentioned this a little bit earlier. There is definitely access disparity, not here in the UAE, but different parts of the world. We have to truly understand that aesthetics and cosmetics is not really just vanity. It definitely have an implications in our mental well-being. Skin of color, it is very important. Everybody here is not Caucasian. We're basically, the populations, I can see the 5 minutes, yeah, thank you. If we see the population group here, it's very heterogeneous. We're looking at patients from all the way from type 1 all the way to type 6. So we have to be very careful when it comes to those type of patients in skin of color. And finally, also truly try to understand the ethical imperative. Now, social media, and I go backing into social media. I'm a big user of social media, not a very strong one, but I do use it a lot. We have to understand that us physicians, we truly have to take into considerations the following. Unrealistic standards. Show your before and afters, but show your before and afters. Okay, don't take other before and afters and don't kind of filter them. Okay, that's how it's supposed to be. We have to try to understand that there is a psychological impact. The social media feeds on that psychological impact. And that's the whole point of the algorithm. You'll be very surprised how it picks up on it, and then it will just promote certain procedures for certain individuals. And of course, there's an ethical dilemma when a patient comes, wants the procedure to be performed, and you basically have to tell them, no, you don't need to do that. So what are the best practices here? Use authentic before and after pictures. Avoid fear-based. I've seen a lot of doctors out there on social media scaring people. Be careful of that mole because it could be melanoma. You don't have to. You can educate them without actually fear-mongering. This is very, very important. And highlight healthy perspectives and representation of beauty. That is very, very crucial. Case study, for example, in dermal fillers. And this is very important because what's happening now with dermal fillers is it normalizes things that are not considered to be normal. Look at this, the overfill syndrome. This is an example, for example, of Madonna. And little small pieces that we kind of add to our patients changes their normal perspective of how they look like later on. Because what can happen, you can develop problems such as complications, and these complications can occur from being too overfilled. Now also lightening practices, skin lightening practices is extremely important because there's a lot of basically push out there to lighten the skin tone. And we truly have to understand that it's not supposed to be the case. We should own up our own skin tone. And you'd be surprised the product market for skin lightening is huge. Why is it? Why can't people just truly understand what, that their skin is supposed to be the way that it's supposed to be? If you have melasma, if you've got a pigmentary problem, if you have post-inflammatory hyperpigmentation, I understand. But why can't we just kind of realize that our skin tone, our normal skin tone, is something that's considered to be beautiful? So skin lightening practices plays a huge role, and the WHO actually stopped the utilization of certain ingredients in those agents, such as, for example, mercury. So aesthetics and medicine is preventative care. It's beyond vanity. Early interventions provides better outcome, boosting confidence, reframing. 2 minutes left?
2
Okay.
minutes, Dr. Hassan.
All right, I can read. I'm wearing my glasses, I'm good. All right, so reframing aesthetics care and the role of dermatology. So toward the framework of ethical aesthetics is we have to respect the autonomy of our patients and their cultural diversity. What is beautiful, for example, in the Middle East could be different from the Far East, could be different than South America. So we really have to try to kind of look into our cultures, especially here in the UAE, because we see people from different parts of the world. Physician accountability is extremely important, and also follow evidence-based transparency. So the future of ethical beauty, regulation and policy shaping is important, especially in our government bodies. I think this is crucial. AI and automated consultations are coming. Okay, you'd be surprised. You can always chat GPT your consultations. I had a patient come in, I was doing a consultation for the patient and ChatGPT at the same time, okay? And also public health collaborations plays a huge role. So in conclusion, ethical beauty is about care, not just appearance. There has to be a collaborative approach that's needed for sustainable impact. And pretty much this is written in Arabic. The meaning of beauty, in short, is the goodness of a soul, self-respect, and purity of the heart. And with this, these are my final conclusions here. I'd like to welcome you all for our meeting, which is basically going to be held in the end of March, which is Dubai Derma, which is going to be held in conjunction with the Asian Dermatology Association. So it's quite a large meeting. And of course, I would like to tell everybody who was in attendance that Dubai is bidding for the next World Congress of Dermatology 2031. So if you are a member of a national society or an affiliate society of the ILDS, please make your way to Guadalajara, Mexico in June of 2027 to vote for your city, Dubai. Thank you so much for your kind attention.
Thank you. If there are any questions, please download the app and we'll be able to answer 2 of your questions, and if not, they will be answered through the app. It's my great pleasure now to introduce Dr. Naif Al-Nomar, who will speak about hand rejuvenation and what works best. Thank you, Doctor.
Hello, everybody. Good afternoon. Thank you for inviting me. Thank you for the organizing committees. Thank you for the chairs. Today I will speak about hand rejuvenation and why it's important. I have no conflict of interest. Why hand rejuvenation is important and why we have to talk about it and why to make it like overlooked in our practice. So the visible sign of aging, usually with a volume loss, prominent tendons, prominent veins, prominent subcutaneous fat. So it is usually a neglected area. Why it's neglected area? Because it's overlooked in the practice. Most of our clients or patients will come and have a consultation about their face, their nasolabial fold, but they are rarely talking about hands. So the aesthetic disharmony between an youthful and aged hand is there. So the growing awareness of hand rejuvenation is there. It's through ChatGPT, as Dr. Hassan is saying, through the social media. So it has to be in your aesthetic toolbox. So what is the sign of age-related hand? There is fat atrophy, volume loss of the subcutaneous fat, collagen and elastin loss, venous dilation and prominence, bone resorption, and tender prominence. So what is the anatomical danger zone? There is superficial vein, superficial venous plexus, but usually it's not that dangerous. because the arterial plexus are deep, and when we are injecting hand, we should be between dermis and subcutaneous fat, so we are fine. The sensory nerve, the dorsal branch of the ulnar and radial nerve is there. So sometimes after the injection using cannula, you will have some numbness, but usually it will last 1 to 3 days maximum. The extensor tendon, they are usually deep. So if we are injecting in the right plane, we will not hit any tendons. So the safe injection plan is usually the dorsal subcutaneous space between the dermis and the superficial fascia. So what's the patient selection criteria, which is the most important thing? So the ideal candidate is any patient with the age-related sign of aging for the hands, like as we said, fat loss, prominent vein, or prominent tendons. The contraindication, patient with autoimmune or peripheral vascular diseases. So medical history is very important. And set up the realistic expectation of the patient about what's going to happen and when we will see the result based on the tool that you are using. So what are the tools that we can use to do hand rejuvenation? It's dependent on the need of the patient, but usually we use this dermal filler and biostimulators, autologous fat grafting, laser and light-based devices, PRP, chemical peels, and microdermabrasions. So let's start with dermal fillers. So dermal filler can be hyaluronic acid, calcium hydroxyapatite, and polylactic acid. So for the hyaluronic acid, it gives you an immediate result. The advantage that you can always reverse the things with 100 days. The problem, if you inject it superficially, you might have Tyndall effect, and some patients will complain about pigmentation over the hand, and it's a Tyndall effect. What I like to use calcium hydroxyapatite based on the patient need. So if the patients need volume restoration, I will not dilute it. If the patient needs skin quality rejuvenation, I will dilute it 1-to-1. PLLA is one of the tools that it can be used. I rarely use it because sometimes if you have nodules and you don't have a subcutaneous fat, it will be obvious over the dorsum of the hand. So filler selection is very important. If the patient needs an immediate result, if she is having an event or whatever, you can use HA, but the product of choice is calcium hydroxyapatite. You can inject calcium hydroxyapatite from proximal to distal or from distal to proximal using cannula, 25 gauge cannula, 50 millimeter. So in here, I would show you that I usually inject from proximal to distal using one entry point. In this patient, for example, I don't need volume restoration. I'm using 1-to-1 dilution. Sometimes I always combine calcium hydroxyapatite with HA fillers, like, for example, B-balance or low molecular weight HA filler. Why? To give hydration and at the same time to give the biostimulation later on. The next is autologous fat grafting. Of course, autologous, it's from your own body. It has more advantage. The fat cells itself stimulate stem cells. So this is the main advantage. The disadvantage is a procedure that you have to harvest fat first and then inject it backward. We have two. We have the micrografting and we have the nanofat. The micrografting for volume restoration. The nanofat, like more smudging of the fat cells, and it's only for rejuvenation. So next, laser and light therapy. So what we have a lot. We have IPL, we have fractional laser, we have Q-switch, we have BDL, we have the fractionated laser 1927, based on the patient's needs. But usually IPL for pigmentation and vascular, fractional for enhancing the collagen and improving the texture of the skin, Q-switch for the pigmentation, and BDL for telangiectasia and spider vein after sun damage and aging. So what is the protocol of the laser? So the combination laser approach is the best approach. because you can tackle everything, because most likely if you have an aging hand, you will not only have one aging sign. You will have like pigmentation, volume loss, and for example, telangiectasia. So the combination is very important. The sequential treatment plan, if you are treating pigmentation and treating telangiectasia, for example, you have to treat the telangiectasia first and then treat the pigmentation with the Q switch. The reason behind that, if you treat with the Q switch first, you will have erythema, and this will be competing chromophore for the telangiectasia. The post-procedure care usually like healing cream and topical antibiotic. What about PRP? PRP is like from your own body. You take blood, harvest, it's good, but its yield only increase the quality of the skin rather than the volume loss. Chemical peel, AHA, BHA, TCA, all recommended to treat pigmentation and improve the texture of the skin. Microdermabrasion is old as gold. This is an old machine that can be used. I don't use it recently at all. So the protocol always to use first laser and then treat the skin. So the combination approaches, the synergistic effect of all what we said before. This is the best module how to treat hands or how to rejuvenate hands, is to have the multimodal technique. It's not only laser, it's not only biostimulation, it's not only chemical peel. But the art behind this is how to sequential this one. So if I have a patient, which is very common, if you have a patient with aging hand, you will have volume loss, we have prominent tendons, you have pigmentation, and we have telangiectasia, for example. So the most important thing is to treat first pigmentation and telangiectasia, do peel, and do your filler or biostimulation at the last. Why? Because filler and biostimulation, if you do it at the beginning, definitely it will have an effect of the other procedure that you're going to do. So the common complication, easy: bruising, swelling after the procedure, nodule formation or collection. If it's like short term, it can be massaged. Asymmetry, pain and tenderness, which is all okay. So if you inject at the right plane, usually it yields a very low complication rate. What is the serious complication? If you have a vascular occlusion, if you are injecting deep, if you are in the wrong plane, you might have vascular occlusion and peripheral vascular occlusion for the tips of the fingers. Infection, granuloma, especially if you are using PLA, and usually it's treated with intralesional corticosteroids with 5-FU. So what are the emerging new technologies? BDRN and the combination of the BDRN, of course, if you are using it for treating the knuckles, for example, the combination of the BDRN, the market is full of the combination like BDRN with glutathione, BDRN with niacinamide, BDRN with peptides, allograft adipose injectables, which is new, emerging in the market, which is, it's an fat cells from other human, which is injected in other human. So it's allograft adipocyte injectables, exosome treatment, and the new energy-based devices. You know, now every now and then you have a new devices for pigmentation and rejuvenation and fractionated laser and combination of two devices in one device. So in conclusion, hands rejuvenation is an essential part of your practice, and it is mostly overlooked in the aesthetic practice. And you can, if most of the patient will come for face consultation, always you can emphasize the hand rejuvenation. So hand anatomy changes and age-related changes and the disharmony between face and hand should be corrected. Combination is the best technique to treat hands. Patient selection is very important, and patient tailored plan of injection is very important. The emerging technology is there, like PDRN and the other, and we should follow that, especially for the knuckles, that we don't have anything for the knuckles. At the end, we we are bidding for the 27th World Congress of Dermatology, which is going to come in 2031. Saudi Arabia has bid for Expo for the first time and won. And they bid for the football, the global soccer, and they won. And now we are bidding for the World Congress for the first time, and hopefully that we win this one. And thank you so much.
Dr. Maria. Welcome back, Dr. Maria.
Yes.
Dr. Maria will talk this time about non-surgical treatment of the peri-orbital area.
Yes, thank you, Dr. Fatma. Yes, so I would like to talk about the treatment options we have for peri-orbital rejuvenation. We know that youthful face, the focus of attention always goes to the mid-face with malar and zygomatic projection. And the focal point of the mid-face are the eyes. So, according to Dr. Sam Hamra, he was a plastic surgeon and the originator of the deep plane facelift. And he always said that a youthful face is characterized by two things: high cheek mass and the absence of a lid-cheek junction, meaning that there is a smooth eyelid-cheek transition, there is no visible tear trough, and the lower eyelid skin is firm, and there's a short vertical distance of the eyelids. These are very, very important characteristics of a youthful face, and it's the first place that attracts the onlooker's attention. We know that there are so many anatomical changes that occur in the periorbital area, including, of course, skin atrophy, changes in the muscles, hypertrophy and atrophy, ligaments, we have bone resorption, and we have the superficial and deep fat compartments which move and dwindle with time. In terms of skin changes, we know that the eyelid skin is the thinnest in the body and very susceptible, therefore, to degradation and showing the signs of aging. The epidermis and dermis thin out, and there is a paucity in the levels of type 1 collagen and type 3 collagen. And this is has been very well established. You can see on histology in young skin, dense with collagen, no interfibrillary spaces, and with age you have significant interfibrillary spaces and degraded collagen. Similarly, studies have looked at the quantification of procollagen type 1 in youth and in age, showing a significant decline. What about the muscle, the orbicularis oculi muscle? We know that there is hypertrophy in the lateral fibers, and this is what leads to crow's feet and eventually static lines. And we have laxity and loss of tone medially, which ultimately results to scleral show in some cases. So the volume loss is contributed by several things, one of which is also bone resorption. We know that this is a difference in the skull of a young cadaver and an old cadaver. You can see the bone resorption and this inferior medial increase in the width of the aperture. And therefore, what this means, what it indicates is that there is no more significant support for the soft tissue above it. So there is no longer the skeletal support. Similarly, the superficial and the deep fat pad compartments begin to decrease, and some of them, they move. So what are we supposed to do to combat these changes, and how can we reverse them? With the non-surgical treatment strategy, we have to take care of the skin, of course, reduce discoloration like pigmentation, like erythema, like vascularity, and replace volume in the subpalpebral groove to get a comprehensive rejuvenation of the periorbital area. In terms of the modalities for skin, we have the injectables, including botulinum toxin, PRF, PRP, exosomes, all of the injectables, and we have the energy-based devices. So with the injectables, we always place the toxin as being important to reduce dynamic lines. But we do have evidence that botulinum toxin has a remodeling effect on the dermis. So it's more than that. And this has been shown in even monozygotic twin studies. So there's solid evidence for that. So there's nothing wrong with having a protocol of regular botulinum toxin treatments. With the polynucleotides, again, some studies have shown improvement in elasticity of the skin, improvement texture, and this is our patient after 3 sessions showing, yes, there is some improvement in the skin. But to be honest, the jury is out with these polynucleotides and exosomes because we do not have high-quality randomized control trials proving their efficacy. It's just a matter of what you see in your practice. What about the energy-based devices? Now here we have, this is all based on solid scientific evidence. Our treatment of choice generally for non-invasive skin rejuvenation is the broadband light. The broadband light system emits a full spectrum of wavelengths from 400 to 1200 nanometers. The visible part of the spectrum is absorbed enters to different depths in the skin and targets microscopic epidermal damage, namely pigmented lesions, vascular lesions, to destroy them and eliminate them from the body. Moreover, the longer wavelengths in the near mid and infrared range are absorbed by water in the skin to various extents. They heat the water gently to 40 to 50 degrees and promote neocollagenesis by releasing heat shock proteins. This ultimately results in thicker and healthier skin. And this is just the first histological study that was shown to show exactly how on histology the skin is rejuvenated. And since then, there are many more studies. So this is our go-to for our patients generally in the clinic, because now we're living in an era of regenerative aesthetics. The days of pumping are over. So we see here, for example, this patient, she is actually a candidate for fractional resurfacing, if not full resurfacing. But she absolutely did not want. And the reason I'm showing you her frontal picture is to show you that she is not smiling. So before and after 4 sessions is not Botox. It is purely the effect of this broadband light system. Look at the total elimination, and these are static lines. They're not dynamic lines. The skin has already been etched by years of expression. Now, we know we have some constitutional darkness in our region. Many of our patients in this region have dark circles. And we realized we were doing full face. Of course, we do full face. Now, some people do want just eyes, and we routinely do the eyes. You can see after 3 to 4 times how not only is the color lighter, brighter, akin to the rest of her skin, but the fine lines and wrinkles are reduced, and there is even a slight plumping effect of the skin. It looks like she has a little bit of filler in her lower eyelids. Again, here, the same thing. So we routinely use it for eyelid rejuvenation. Of course, more powerful means of rejuvenating eyelid skin is by literally burning it off with the fractional ablative lasers, of which we have, 3 wavelengths that are ablative, the 2790, 2940, and 10600. So 3 options. When we use these wavelengths, water in the skin absorbs these wavelengths so avidly that it vaporizes the skin, it bubbles, and with it go part of the tissue. So you get removal of the skin, you create microthermal treatment zones, and this induces a powerful wound healing reaction. The surrounding tissue helps the recovery, and you have very extensive remodeling of the dermis and epidermis. Again, a lot of histology in the literature showing the significant power of these fractional ablative devices. Our device of choice is a pro-fractional erbium YAG 2940 nanometer, which is quite unique in that it's totally tunable. So, of course, again, the chromophore is water, but we can literally select the depth. We can go up to 1.5 millimeters, so 1,500 microns in depth. And we can, of course, select the density per pass. And another thing is that we can titrate this laser. We can customize it to act like either pure erbium, as you will see now. So if we can do pure ablation, this is like a cool laser, just erbium, Or we can add coagulative zones to it. We can add heat by delivering sub-ablative energies. So we can add C1 is C2, more heat, like a YSDG laser. C3, it's now become exactly like a CO2 laser. So we can choose, according to the patient's skin type, do we want a CO2 or do we want pure erbium, like for darker skin types. So it's a very versatile device. And again, histology showing without coagulation, a clean ablation. With progressively increasing coagulation, you have more of a thermal effect, which gives, of course, obviously better tightening. So these are our results after one single session. You look at the clearance of all the dyschromias, improvement, even improvement in the deflation under the eyelids because of thickening of the dermis. Okay, so this is another one. Look at the crepiness of the upper eyelid. These are all single sessions. And you can, for example, on this eye, it was done at 250 micron depth. On this eye, it was done at 150 micron depth because there is a difference in the extent of laxity. What about volume restoration? Of course, a very integral part of eyelid periorbital rejuvenation. We know that when we develop this groove, it can be either simply a tear trough, which is restricted to the medial part, or a palpebromelar groove, or the whole subpalpebral groove. We need to be careful to check history of malar edema, and in this area, always, always inject supraperiosteally and use a non-hydrophilic filler. People are tending to inject in the eyelid proper. There is no fat in the eyelid. The eyelid is skin, muscle, and then the septum. There is no fat. There's no point in filling. You need to fill at the level of the depression, namely between two ligaments, the orbicularis retaining ligament and the zygomatico-cutaneous ligament. There is this space known as the pre-zygomatic space. And when you inject deep on the bone and the pre-zygomatic space, your correction is totally imperceptible. It's very smooth. Because if you inject superficially and you think you'll massage it, it will go deep, I have news for you. It will not go anywhere because you have the orbicularis oculi muscle in between, sandwiched in between. So you will have to melt the filler. If you inject deep, 90% of the time, it will not retrograde and go superficial. It will remain buried deep. So this is a patient who is only 28 years old. And by the way, this deflation subpalpebral groove begins at a very young age. You see patients 27, 28, already they have this aspect of fatigue. And so you can see treated versus untreated. Again, treated versus untreated, but the key is to inject on the bone, which, by the way, stimulates your bone regeneration. And if you have a patient with mild eye bags, of course, this is a surgical case, but when the eye bag is juxtaposed to a tear trough, it looks even worse. So the minute you give a little bit of plumping and reduce this groove, it's like an optical illusion. The area looks smooth and the eye bags don't show anymore. Again, you can see here, you can literally see the orbit, and when you fill it, everything looks smooth. Some cases, on top, we do a laser, fractional resurfacing laser, to improve also the skin. So as Dr. Naif said, it's all about combination. Here too, a combination of filler and laser, filler and laser. So in conclusion, this delicate infraorbital area is the first to show signs of aging, and sometimes at a very young age. So we need to use combination procedures to improve the skin texture, the skin elasticity, eliminate discoloration, and the toxins for the dynamic lines, and only hyaluronic acid fillers in this area to restore volume. Thank you.
Now it's my honor to invite Dr. Ahmed Laisa to the stage to talk to us and learn about his clinical experience in different cases treated with laser. تفضل Dr. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. I have nothing to disclose. The first laser I used was 1993. It was a ruby laser for hair removal. And since then, I've been using a lot of lasers. No single day with no patient complaining from laser abuse. And I'm seeing now side effect complication more than what I treat, just because of the exaggeration from some of my colleagues regarding the result, either from the injectables or from the laser. So I will share with you some of this experience. And I think there is something called now pico laser abuse. And no single week without complication or side effect of pico laser. Why? Because pico laser has intensity here. So pico is really highly intense device. And it's very tough in dark individual to be used, because even with that low parameter, sometimes you get some side effect. So be careful. It is really very strong device. I do have pico years ago, and I use it mainly for tattoo, freckles, nevus of oota. But when it comes to those indications, melasma, PIH, wrinkles, rejuvenation, acne scars, striae, there might be some result with some good hands, but majority are not. So I will not advise anyone from the beginners to use any one of those indications. So I will share with you some of my colleague side effect and complication. I mean, this is PIH from the stretch mark. So why should you use it? Because they told you when they sell the device, it is good for elastin and collagen remodeling. So I think when it comes to dark skin, can you imagine this wavelength will go deep, bypassing the pigment and going to the collagen for remodeling? Give me a break. For dark skin individual, I think it will be very, very difficult. And this is very common, the elbow, knees, and peri-orbital pigmentation, axilla, private area. It causes PIH, and it makes it even worse. So be careful when you use this. Even tattoo, when you use it in tattoo in high fluence, and just remember, there is an epidermal melanin. It might be absorbed more than your tattoo, and you get scar, because this is really happen with many tattoo I have seen treated by pico with less experts. And lip pigmentation. When you use lip pigmentation, the pico, I think the margin for the or the window for the parameter is very narrow. And be careful. And I will not advise anyone to use pico on the lip unless he's very expert with this. Even with nevus of oota, I know it's a good device. But if you have a Q switch, why you use it? Because I think you might use it at the end with low fluence, 1064. But I think you will get dyspigmentation, because it will damage the wanted epidermal melanin before it go to the deeper wanted melanin in this. So be careful, and pico laser in dark skin may cause dyspigmentation and scarring, and I have seen more and more. And defending some of my colleagues because they've been sued because of the pico laser. So be careful. This is a rhinophyma. When I refer it to plastic, they don't want to do it. And even for the rhino, the ENT colleagues, they don't like it for some reason. No one likes to do dermabrasion. So I've been doing erbium, but it is a bloody procedure, and you have to be very careful when we use it, not to overdo it. And this is just a few months ago, he came to me and the end result. So, and I've been doing more and more nose, and I encourage everyone to do erbium or CO2 laser for rhinophyma, because plastic, ENT, they don't like to do those cases, some of them, of course. And before, they do microblading for the alopecia totalis, but nowadays with the JAK inhibitors, we get good results. So I'm getting more of those. Those very easy. Microblading is very superficial tattoo. So I encourage everyone to do 1064, and is excellent result. And when the device being selling to you for vascular 1064 device, be very, very careful, because the long pulse 1064 is a non-perferic device. So if you do 2, the hemoglobin will turn to be methemoglobin and there will be scar. But it's an excellent, this is my daily procedure for all those veins. But you have to know how to do it. And this is my parameter, but no stacking. If you do, you will not see purpura. Don't do again. It's enough. If there is no planching effect, so don't do it again. Bring them again, okay, but don't over does. And when you do the device, it should be away because this is 1064. It might be absorbed to the retinal pigmentation. And this is some of the cases I'm seeing more and more. 1064 facial vein is very dangerous and scarring. And be careful. Be careful about those devices because you will see really permanent scar from 1064. And the most dangerous area is this. Don't do any vein here. Simply because there is an arterioles here, and I think it is best to avoid this area with 1064, not to cause any. The telangiectasia is much easier. It's 532, less scarring, but the hydrostatic pressure here is very high. So the recurrence is high. However, it's an excellent result. I'm writing all my parameters. You can copy this. But please, for the photo, don't, share it with your social media because I've been sued just because of one patient. Use the parameter, but don't share this with anyone in your social media, please. So you might cause a scar if you do more and more, but it is less common than the 1064. And melanonychia, I do it, a lot if I exclude the potential malignancy. So any pigmentation of the nail, regardless of the cause, I will do it. Even if the fungal, because I think fungal need heat. So you can kill the fungi by the heat. So we know 1064 can do it. So any pigmentation, if I rule out the malignancy, I do it because I think you will get a good result regardless of the cause. Now, sometimes I don't know what's going on here, but she cannot use the nail, polish. So this is why I at least decrease the pigmentation of the nail. So any nail pigmentation, if I exclude the malignancy, I do laser. I do laser. Oral, because it's almost painless. Any pigmentation in the mouth, please treat it and you will get good result. And always use Q-switch or Pico, 755 or 1064, but I think you will be getting a good result regardless if it's minocycline or any other cause. If she or he didn't like his tongue, just use the laser, you will get good result because you can be aggressive and really good result. And gum, smoking or for any reason, I think in one session, I'm getting gum result way better than the lip or the tongue. The gum is really, but it is 1064, 755, 4 millimeter and 5 joule per cent. 532 doesn't work, 1064 doesn't work. Only 755 for the gum. I always encourage them not to smoke, and I have enough patients that they quit smoking just because of this procedure. When I make the ad, it's encouragement for them to quit smoking, which is really good. Hemangioma, when do you stop? This is 2 years on beta blocker. For the last 6 months, no change. So why they keep doing it? Pediatric cardiologists, they just keep giving and non-stop. So neither the dermatologist or the pediatric cardiology will stop. So at certain stage, you should go. When you see the fibrotic, more the vascular, do it, but don't do it early. If you do it early, they get scar. So late is always good. When there is no consensus about this, but there is a good review, I will show it to you. You can review it and make judgment when you do it. But I'm getting good results because I did one, and then there is a huge difference. But this is after 6 months, 1 year of beta blocker. So this is, and again, if you keep giving beta blocker, it will not improve this. But in one session, it's an excellent result. So apply vascular laser after 6 to 12 months of beta blocker will shorten the course of beta blocker, for sure. And this is a good recent review about this issue, because we used to say, don't use vascular laser. Now we say use it, but probably after 6 to 12 months with excellent result to minimize. Rosacea, don't touch any, vascular laser or IPL when there is any papulopustules, because you will flare it. And rosacea, treat it topical oral for 1-2 months, then do the vascular laser, and then you will be good result. This IPL induced. So I think this is just a few weeks ago. I mean, she said, listen, I'm getting married, I need it. I said, there is risk, and it happened. It was a good learning curve for me, but as long as she knows, I give it a trial, but I think we aggravate it if we do it. But nowadays, I avoid. Good, thank you. So acne hypertrophic scar, always treated with erbium. Excellent result, the nose. Always the nose is, I mean, good healing. And this is before and after by erbium or CO2. And I have seen enough cases that be treated with isotretinoin, thinking that this is kind of acne or no, this is scar. This is called hypertrophic acne scar and improve, and she can do makeup easily. Don't touch any nevi if it's atypical, for sure. Any atypical, but I've been treating for years and years, and this is an excellent review if you want to see how many, years ago with safety profile very high, the melanocytic nevi. And I've been doing this more and more, and now I have an excellent skills. I can give just a talk about nevi and laser, and all the difficult nevi in the eyebrow, in the eyelid, which is excellent. Plastic surgeon doesn't like to do this because of the eyelid eversion as a complication. So I think you can do any nevi if you exclude 100%, 1% risk of malignancies. And I think you can do laser hair removal, and then erbium, then alexandrite. And always think of surgical if it is dermal. If there is nests, I think you cannot do it by laser, so surgical is good. And eyeliner, one touch. I think this is like microblading, but always know how to do metallic eye shield before doing this. You cannot do it. Unfortunately, I have seen some physicians do it without. Angiofibroma, excellent result with the, it has to be purpuric. It is PDL 595 in one session. They got an excellent result. This is a patient with a discoid lupus. I've been giving topical steroid and treated with even some systemic, but no result. With one laser, PDL, excellent. So connective tissue disease, you can treat it easily. And this is lupus patient with PDL. So this is not a UV. This is a visible light. So it's allowed to do this, and you have to get purpuric to get good results. So all my lupus patient and dermatomyositis, I do vascular laser, excellent. When you do isotretinoin and they're left with this, atrophic erythema, so do laser. In one session with the PDL, you get excellent result, but it has to be 1.5 millisecond or less. Tattoo, this is good result? I think it's excellent result for us as a dermatologist. 2 minutes. So I think patients was not happy. Why? Because he said, listen, the shape is the same. So I think counseling the patient for realistic is more important in tattoo. I'm seeing a lot of patients tattoo treated with 70, 80% better for us. But for the patients say, no, it's still the shape is there. What about home devices? I think now we see more and more. I think it is good. And with different IPL, LED or heat or infrared, I think, or laser for hair reduction, photo. But I think this is excellent device in a private sector for laser hair removal. And be careful before you buy, this is a real or a fake. And this is a PIH from the home device. Dermatosis, I don't suggest any kind of laser. With a 30 years experience, I refund them, I will say I have no. Dilated open pores, still, we are not yet. I have done enough fractional laser with the no good result. You don't see which one is better before or after. And melasma, Baker's nevus, stretch mark, white stretch mark. And I think I'm so proud I'm from the Gulf area. Why? Because 2 countries now competing with the World Congress. So if Dubai win, I will be happy. But if Saudi win, I will be more than happy. So please vote for us to make myself very happy.
Thank you, Doctor.
Doctor, I have a question, Dr. Ahmed. Thank you very much. It's very impressive presentation. In my practice, I use both. I use pulse dye laser and I use Q-switch YAG 1064. Now, I see you in your presentation mentioning for telangiectasia on the face. Sorry, you use for telangiectasia on the face. For the telangiectasia on the face, you use Q-switch YAG, although but you also you have pulse dye laser. So why you don't use the
PDL in telangiectasia recurrence very high. PDL, don't use it, but you might get some good result, but the recurrence is very high because I use PDL in rosacea, but when there is telangiectasia is very high hydrostatic pressure. PDL will not work. It might work for 1-2 weeks, then recurrence. But 532, I think, is the best for facial telangiectasia.
Oh, thank you very much. Thank you.
Dr. Ahmed, also for the fractional CO2 laser. So a lot of centers has fractional CO2, they don't have VDL.
Fractional laser for what?
For acne scars. Because the acne scars and also the erythema for acne scars, so most of them we have fractional CO2, but we don't have sometimes vascular.
Fractional for acne scar.
Yeah.
PDL for erythema acne scar.
Yeah, but if we don't have VDL and the patient has acne scar,
So
but also erythema.
treat the acne scar and send them to me for PDL. No.
Thank you.
Thank you very much, Dr. Ahmed, for this very interesting talk. I'm happy to welcome Dr. Dani Touma, who will talk about aesthetics of skin cancer management. Thank you, Dr. Dani.
Thank you very much. And thank you again for the invitation this year. And, this meeting keeps getting, more and more wonderful. My talk is on the aesthetics in managing difficult skin cancer, because as we treat skin cancer, it's important that once we clear the tumor, the final result is more than acceptable, and sometimes it can be really excellent, and paying attention to that is very important. Okay. So the morbidity from skin cancer is usually not a big problem that we deal with unless the skin cancer has evolved tremendously. But the problem sometimes is the over-treatment from treating skin cancer. And you'll see here some cases of really unnecessary scarring with skin cancer treatment, from curettage and desiccation for a superficial basal cell carcinoma, from a deep resection for a melanoma, surgically excised, from exuberant cryotherapy for minor actinic keratosis on the face that left atrophic depigmentation, and from radiation therapy for a superficial basal cell carcinoma that still recurred, as you can see, in a dermatomal fashion. And this is a surgical procedure for what you can see, a small, nodular basal cell carcinoma, where the margin was clearly, at least a centimeter around, causing major surgery that is needed, major, done under general anesthesia, major morbidity for the patient, and of course, major cost. So, of course, when you're treating with basal cell or squamous cell carcinoma or melanomas in our practice, it's, having a good diagnosis is key. Without a good diagnosis, no treatment can be designed. And as expert dermatologists, I think it's always nice and rewarding to catch skin cancer very early, like that pearly papule on the lower lid, or that small plaque on the ala, or an even less noticeable plaque on the cheek, before these lesions get to the dramatic growth on the left, on the right. Same thing with melanoma. Whenever we can find them early, we're going to get better cure rates. We're going to have smaller excisions with better scars, of course. So the goal of the treatment of skin cancer is always achieving the highest cure rate, but keeping in mind that we need to achieve as much of an ideal aesthetic outcome. And this is possible. So the treatment of skin cancer, of course, is the standard of care is generally surgery. And whenever you have access to Mohs surgery, it's even better. Alternatively, there are treatments that can be indicated in larger tumors, in tumors that in elderly people, or in tumors in very delicate areas. And my personal favorite, after many years of practice, are the topical immunotherapy using lasers, or topical photodynamic therapy, or topical or intralesional chemotherapy using 5-FU or methotrexate. I personally almost no longer use cryotherapy, even less electrodesiccation with curettage or radiation therapy. And I'll show you examples of treatment. So the standard of care for excising any non-melanoma or a melanoma skin tumor is well established, a 0.3 to 0.5 centimeter BCC for a BCC or an SCC. My personal recommendation is to curette these lesions first, because you'll have a better definition of the tumor margin, and then take your 0.3 or 0.5 centimeter margin. For in situ melanoma, well defined, it's 0.5 centimeter, though we know that on the face, a lentigo maligna might require a much larger margin. For melanoma that's less than 2 millimeter in depth, it's usually 1 centimeter, or 2 centimeter for deeper melanomas, but that can vary depending on location. If you have access to Mohs, and we have Mohs here at Skin Experts in Dubai, the nice thing about this procedure is our ability to process the tissue immediately on the bedside. So we excise the tumor after curetting, taking a 1 millimeter margin, and then we process the tissue. We're able to examine it directly and determine whether there are still tumor cells or not, go back, take specifically from that area, and that allows cure rates approaching 99% for primary tumors, maybe a little bit less for recurrent tumors. And the golden part about this procedure is the ability to preserve tissue as much as possible, so we obtain really smaller scars. That's a procedure everybody knows, ideal for basal cell, squamous cell, more and more used for lentigo maligna, and even invasive melanoma, locally invasive, and fibrous tumors and angiosarcoma. This is why this procedure is important. Here's an example of a 6 times recurrent basal cell on the nose, and you can see that the tumor is not well defined. After Mohs, you can see how far it has extended, cleared and then treated with a skin graft, and it never recurred. Some examples of defects that are treated. That kind of training allows us to do proper reconstruction with sometimes linear closure, a transposition flap here, sometimes bilobed flap. This was a basal cell carcinoma removed with Mohs, of course. It would be kind of, not a great treatment if this lesion is repaired with such a nice flap, but there are tumor cells at the margin that will come back later on and infiltrate under the flap, and will be quite difficult to be treated later on. Another example of a larger defect, if this is a defect after Mohs, had it been done with a larger margin, it would be much more difficult to treat. And this is a combination repair with a pedicle flap and a rotation flap. This person has a morphiform basal cell carcinoma, and you can see really the extent of these lesions and the importance of doing Mohs to clear these, and then do the proper reconstruction with a dual kind of transposition and rotation flap. Sometimes not much tissue is available to advance skin, and doing a skin graft is important, in this case from the concha that has nice porous skin that resembles skin of the ala. More difficult areas like this SCC on the nail bed, Mohs is highly indicated, because we're going to be able to preserve, to clear first the tissue, the tumor, and then preserve as much as possible of the tissue in this area. Of course, the nail had to be removed here, and we can see the tumor 6 months later, well healed, no recurrence, not the best aesthetic result, but couldn't do better. This patient had an HPV-related SCC on the penis. His urologist recommended partial penectomy, and doing Mohs on him was, allowed me to preserve his skin. You can see him 9 months later after a skin graft, after removing the tumor with a couple of stages. DFSP often extends much farther than the apparent limits. And again, Mohs is highly indicated in those cases. So the ideal scenario for Mohs is obviously an ill-defined tumor, a recurrence, or an incomplete excision, the locations on the face that are critical, the central face, the ear, the lip, larger size, definitely a perineural involvement because the tumor can go farther than the apparent margin, or anybody who wants a smaller scar, younger patients, or whenever a complex repair is anticipated, doing Mohs will always make it simpler. There is more and more data. We don't have a lot of time to discuss them, but today even melanoma can be treated with Mohs using special stains such as MART1 or SOX10 on fresh tissue. This is a very old case of mine where a 2 centimeter margin was taken, and you can see the extent of the reconstruction that is needed. They still heal well after time, but I think in the future, more and more cases of melanoma will be treated with Mohs surgery. The non-surgical alternatives are things that I really enjoy doing because in special cases, I think they're very important. As I said, I do almost no more cryotherapy. For actinic keratosis, just like in this case, I use the erbium laser to ablate. So no more just freezing, getting blisters, getting prolonged healing, just ablate, and my endpoint is reaching the papillary dermis. And it's a little bit hard to see here, but I look for these tiny capillaries or little bleeding points, and I know that I'm already in the papillary dermis, and that's usually enough. And the healing is fast and doesn't leave scars or hypopigmentation. This is topical PDT, which I would recommend in patients who have diffuse actinic damage and diffuse actinic keratosis. 5-ALA, light, could be blue light, could be red light, or even ambient light, and you get nice clearing of diffuse rather than use 5-FU and very dramatic healing times. For superficial basal cell carcinoma, topical PDT can be very appropriate, especially in younger patients or in delicate areas where we can clear these tumors with a single session of 5-ALA, blue light or laser treatment with good and if not excellent results. In patients who have multiple tumors, we're not going to do Mohs on a patient like this. This patient has EDV and has lots of SCCs, doing a combination, trying to be quite creative of mild curetting to debulk the tumor, then doing a topical PDT, then following up with imiquimod. You can see that patient 4 years later with no recurrence on any of these lesions. This patient was referred to me with a 4-time recurrent malignant melanoma of the lentigo maligna type. Of course, I wasn't going to do surgery on her, old lady, and had enough surgical procedures. So doing imiquimod, that's reported in the literature, caused nice clearing of this tumor, and I only have 1 year follow-up.
Dr. Dani, sorry, we're almost done with the time.
Okay, I'll go
you can
quickly.
speed up. Thank you.
Laser for the vascular laser can be very important for superficial basal cell carcinomas. The pigmented laser, if you have a pigmented basal cell carcinoma, can be very useful, especially when you have multiple lesions. And always remember, if you have a clear case of keratoacanthoma, using methotrexate can be life-saving, especially in such a young patient who has it in a delicate area. I'll stop here. Thank you for your attention. And if you have any
questions,
questions,
Dr. Dani, for your lecture. Thank you so much. So, do you have any question for Dr. Dani of any one of the speaker in the app? If there is no question in the app, anyone in the want to ask any questions? So, yes, please.
Test. Good afternoon. The question for Dr. Ahmed Al-Isa. Regarding the venous leak, Dr. Ahmed, which
Dr.
is...
Ahmed, the question's for you.
The venous leak, which is better, the pulse dye laser or Nd:YAG laser? And
Nd:YAG, very dangerous, very, very dangerous. I have 2 or 3 cases, bad scar, but it is the best. If you know how to drive it, 1064 way better because it's long and go deeper. But 595, and don't use half millisecond, you have to use 1.5 or 3 millisecond with 3 or 4 stacking till you see purpura. But 1064 way better, but it's too risky.
Okay. And one more question, last one.
Yes, please.
For Dr.
Last
Ahmed.
questions. Yes.
For children having port wine stains and they are very young, 1 year or 2 years, would you pulse them with the PDL or wait?
Yesterday, I have 3 days old. 3 days. Because my message for all the family around me and my neonatologist, bring them in the first. Because you know now, the earlier the better, because the skin is thin and less pigmented. And there is no memory for the pain. So I do neonate a lot now, just because all my neonatologist colleagues, I tell them, listen, send them in the first month.
Yeah, you will give them sedation?
No IV sedation, because too much IV sedation decrease the IQ. And there is data about this. So nobody do sedation because you have to do it 5 or 6 times every month. So no, we do it because there is no pain memory.
But you will not apply
no sedation.
You will not apply any anesthesia?
You can apply, yes.
Okay, thank you.
Thank you for the questions. Any more question? Dr. Jihan.
عفوا دكتور, do you use Q-switch YAG for scarring?
No, I don't use. For scarring, fractional laser, but I don't use a Q-switch.
You don't use...
In dark skin, scarring is way different than white skin individuals, skin type 1 or 2. I have seen enough PIH from scarring, from PICO, or from other devices. Be careful. If they come to you with skin color scar, don't leave them from your clinic with PIH scar. So I think scar in dark individual is different than white skin individual.
Right.
Either fractional with a proper dose, or don't use any Q-switch or PICO in scar. Dark
Sometimes with the fractional also, like patient with scarring, we consider post-inflammatory hyperpigmentation.
I agree.
So even with the fractional laser.
I agree. You have to play it and drive it carefully.
Yeah, thank you. Thank you, doctor.
No other question for the speaker? So with this, we can conclude the session. And we will ask our esteemed speaker to take photo together if you want, please. Thank you.